after transplant, there were already only 70% or 65% of the transplants still surviving. Look now at 2005 data, and you can see that now 90% of those grafts are surviving at the first year. So you can see that there's been that's why I said this article could have been called significant improvement in early post-transplant survival has been seen for all the organ systems, kidney, liver, and heart transplant, much less early graft loss. Now the challenge is that over time, the loss of grafts due to chronic rejection or other causes does continue, at least in the SRTR data. Now there are patients that are lost to follow-up that do still have their kidneys, that do still have their hearts, and do still have their livers. So this only shows the data that's available to UNOS. And so these curves could be shifted upward somewhat by those lost to follow-up patients. In the case of this, perhaps up to 20% of patients have their grafts and are not on dialysis and are alive and are not shown in this data. But this is the data that is available. So what are the takeaways from this information? Number one, children are doing well for many years after transplant. However, we need to look particularly at the outcomes between 5 to 15 years and see how do we improve the slope of this curve so that the majority of patients keep their graft for as long as possible in a healthy condition. I'll move on, but this is, I wanted to share this information with you and kind of discuss it with you. Not because this is bad news, but because we really need to know the truth so that we can focus and get better. And related to this, I did want to focus and show you some data on a study that's been submitted for publication by colleagues from Atlanta and Kansas and Yale, looking at 25-year outcomes. And this is just one slide from their data that they said I could share. But this data demonstrates that the most at-risk groups for 20 and 25-year outcomes are those patients who are in that 11 to 15 and 16 to 17 age cutoff, and that those are that's the pink and the gray, and that those are the kids, the adolescent population that have the most risk of losing their graft. This is data from 20 to 25 years out that shows after 20 or 25 years, the 16 to 17-year-olds are the patients that have lost more grafts than the other patients that are the infant population, for example, even over the same time period. And so we really need to focus on our adolescent population if we want to improve. And the causes of retransplant in this group, again, the numbers are relatively small, so we only had 113 out of the large group, but the majority of the retransplant, even for liver, where there's presumably a lower incidence of chronic rejection, the main reason for retransplant continues to be chronic rejection as compared to these other issues, vascular problems, biliary problems, or infection, or recurrent disease of some other kind. So this is the area that I think we want to focus in from a biologic threat to our patients. And in the liver, and this is really similar in principle to heart and to kidney recipients, we know that part of the reason that we lose grafts is because scar tissue does increase with time after transplant. These are different studies that have shown increasing amounts of fibrosis depending on the year after transplant, and that there's an association with what is known as donor-specific antibodies that may be associated with the fibrosis. So for those of you who aren't familiar with this concept, this study demonstrated in children that the more fibrosis that we had, stage 1, 2, 3, and 4 being the worst, the more there was an association with DSA presence, so that were antibodies against the donor, specific to the donor, present in the majority of patients who had stage 3 and 4 fibrosis compared to the other areas with less fibrosis and no DSA. And this is something that was first shown in the kidney community. Two more challenges, and then we'll talk about how do we get better. So the challenge number 4, and this is something that I've been increasingly convinced of is probably one of the greatest keys to improvement, is how do we monitor and how do we get better at adherence. Just have a couple slides on this, but this is a current issue that we're working on. First of all, we know that something as simple as monitoring the tacrolimus levels or the immunosuppressant levels of our children may be valuable. This is data from about 10 years ago that demonstrated that for patients who have these type of fluctuating tacrolimus levels, this is an actual patient over time, that we can measure this and we can calculate standard deviation variation of this. Really, a patient who's on a stable level really should have a standard deviation of 1, meaning it's not going to vary more than 1 standard deviation. Levels can vary for normal reasons or lab variation or fluctuation within 1 standard deviation, but it takes more than that to cause levels of greater than 2 or 3 standard deviations. And what this just showed is that for patients who had more than a level of 2 standard deviations, the frequency of late allograft rejection was significantly higher in those patients. We translated this into a study among 7 centers called the Medication Level Variability Index Study, or the MALT study. And this was medication adherence in liver transplant. And what this study that was recently published demonstrated was that when children who had received a liver transplant, in this case, had a standard deviation level of 3 or of greater than 2, that the majority of those patients were going to have a acute cellular rejection episode within the year, as compared to patients who did not have that variation. And so, and this was particular, the predictability of this was present for all the recipients, but it was really strong for those patients who were in the adolescent age category greater than 13. And this just demonstrates the importance of using a relatively simple tool like measuring the standard deviation of our tacrolimus levels to potentially predict which patients are going to have rejection. You could ask, so what should we do with this? So one of the things that we're doing with this now is to take this data and then use it to really identify a population that may benefit from intervention early on. So what if we took those patients that have a high standard deviation of their tacrolimus levels and try to intervene through a variety of techniques, such as behavioral support or other clinical support, to help reduce variability in their tacrolimus levers? Can this reduce rejection? And we're doing that study now with a 10-center, multi-center study with many of your sites, I believe, are participating as we are here in Pittsburgh. And we hope that that intervention will be the first to really show that we can prevent late rejection by identifying those that are at risk to be non-adherent or less well adherent. And the fifth challenge is one that I call transparently sharing best practice. How do we do that, and how can we do that better? So there are many different approaches, and I think Transplant Families is a great example of really getting the patient and family voice to be informative to us as to how we can do better. And this is out of a recent report that we published in Current Opinion in Organ Transplantation on different quality approaches that are happening in the community right now. For heart, the Pediatric Heart Transplant Society has done important work to improve the standardization of care within heart transplant patients. In kidney, the Improving Renal Outcomes Collaborative has worked on a learning network approach to improving the standardization, for example, of measuring hypertension and how that can impact long-term graft function. The Society of Pediatric Liver Transplant registry developed a quality improvement committee as well as benchmarking, which I'm going to show you. And they were the first to just identify how variable care was in the liver transplant world. And so we built on that in the Starzl Network for Excellence by focusing on bringing together some elements that were not common in the other approaches, and that is to bring together the innovative and technology partners, the patients, as well as the transplant centers to transparently share practice. We'll talk a little bit about that. This slide just shows you what, in a nutshell, comprises some of the difference between research and QI. And by QI, I mean quality improvement. In research, on the left, we begin with the problem. We come up with a data hypothesis, and we test it. This sometimes involves randomization, one group versus the other. We come up with conclusions, and we publish this. And then sometimes we get additional funding or apply for additional grants based on this. It tends to be very, very focused on a particular theme, and it may be biased somewhat by our experiences, by our expertise, by our particular interests. In quality improvement, we take an issue or a plan that is targeted at some problem that is occurring. We discuss that problem, we identify how we can improve, and we bring together our hospital or our team to discuss how we can improve and make this process better. We implement this sometimes after doing surveys. We do quality improvement methods, and we implement that, and then we evaluate and see how we've improved. The idea is to not really do research, but to look at a problem and attack it via an improvement method, and to see if that makes a difference. Neither of these are the ultimate in how we can improve, but I'll show you how we've used some of the methodology and how we can do better at that. This is data from SPLIT just to demonstrate for liver transplant, and I believe really we could do the same for all the organ systems. When we look at data within our community, we know that outcomes tend to be reasonably good. The difference between 90% survival and 100% survival at a high level seems to be small, but the difference actually can be quite high. And this data showed that there's also quite a lot of variation between centers, which are listed on the x-axis here. These are all individual centers, had varying percent of biliary complications from very low to almost 100%. And for hepatic artery thrombosis, again, from very reasonably low, say 1 or 2%, to over 30% in another center. And you can see how there's quite a lot of variability. How do we take this information and then get better instead of just acknowledge that there is a lot of variation? We summarized this in an article that we just published in Current Opinion in Organ Transplant with our colleagues from all of the organs contributing, and just to show you that there's wide variability in clinical outcome measures among the transplant hospitals in infection, readmission, and reoperation, as well as those two that I mentioned already. One of the things that we did is we generated a center-specific report. And this is available typically to centers in the heart registry, in the kidney registry, and in the liver registry. And it shows you where, this is our center, for example, for these metrics of long-term good function of the liver on monotherapy, just tacrolimus, with these parameters. And this is for Pittsburgh, in which I'm sharing. And it shows you that we're doing within kind of the mean at 1 year. We're a little bit higher than the mean at 2 years, and we're within the mean at 3 years. And you can see the numbers: 70, 43, 15 patients. This is data that each center can use and say, okay, we want to, what are we doing in this time period that we want to get back up and be higher? Or if we're low, how do we improve that and get back into the mean? I think there's several ways to do this that we haven't done yet. And I think all of this is important, and our centers are all working hard at identifying best practice, but this isn't good enough for a couple reasons. One is pediatric transplant is a rare condition. So even at the busiest centers, we need to work together in order to learn together. The second reason is that knowledge and innovation is growing faster than any of us can keep up with. And we need to implement methods that help us to use the knowledge that's available to apply to our field today. And then the third thing is that we need to figure out ways to share our learning and get it out to the nation or to the world in a faster way than the typical route of publishing something and having people then begin to do it. We need to do it as a community and disseminate what we're learning as a community. So this is the rationale for what we call the learning network approach. And this is, I borrowed this from Thomas Friedman's concept of accelerated knowledge and how there's so much knowledge that's happening in his book called Thank You for Being Late. But if you look at knowledge over time, early in the 1900s, knowledge was just growing maybe every 100 years. It would double, they would say, every 100 years. But now we're in this time period where knowledge is doubling, depending on how you calculate or measure it, probably every 2 to 3 years. And we have a limited way of keeping up with this information. We try to keep up with apps. We try to keep up with synthesized abstracts and information. But our ability to adapt is shown in this red line. It cannot grow as fast as this black line unless we do something different. And what we think we can do different is by shifting this red line to a learning network approach to keep up with all this knowledge that's happening in the field. And how do we do that? One of the ways that we want to do this is by really doing 4 things that haven't been well done before. The first is that we need to be more transparent, and that none of the centers, when we showed you that split data, centers, because of being afraid of either regulatory issue or patient referral issues, typically aren't good at sharing all of their outcomes. Only those that are mandatory in some cases. So we wanted to bring a community together that would share transparently and identify ourselves as those that could improve or those that could share their best practice and being transparent. We really wanted to bring family and patients together to inform what projects we would work on, and we wanted to accelerate. If we could show that if you could look back to that knowledge curve and see that knowledge is moving so fast, we typically don't bring together people from industry or technology to kind of spark our thinking, but we needed to do that. And we wanted to bring, obviously, the transplant centers together to impact children. And this is a a shot of our first meeting of the Starzl Network last September in Atlanta. One of the exciting things about this network was that we really wanted to focus on our principles of collaboration, of urgency, so doing our work quickly because the need is great, being transparent, and trying to really work on being innovative in ways that that couldn't be done through traditional research, so that we could develop excellence. And then finally, we wanted to work with existing teams, not against or competing against teams. So we wanted to find teams that were working well with patients, for example, and work together. That's why I think this collaboration with Transplant Families is such a great example. We may learn so much from your work that will help us in our including the patient voice for our challenges in liver transplant. We wanted to focus on liver to begin with because that wasn't being done well in a learning network type approach yet. But there could be some synergy with other organ transplants, such as intestine or thoracic transplant in the future. And so, given these, all of this was made possible by a philanthropic gift, and so we're very thankful for that spark plug, if you will, that helped us to get started. So I just want to show you a couple of slides about the network and just some of the concepts that we developed, and then we'll have time for questions. Right now these are our Transplant Network partners from coast to coast. We're very excited about their participation with us. And the way that we did it, we sent out a pre-meeting survey to centers as well as to patients to focus on what areas they felt were important to really key in on. And these were the family representative responses from different centers. This is a really complex slide, but we asked two questions during our in-person meeting. The first one was, which problem would you like to solve, or question would you like to answer in transplant? And you could see that we targeted them we broke up into 4 different transplant periods: the peri-transplant, early and late post-transplant. But a lot of the common themes spanned more than one time period, such as issues of immunosuppression. Immunosuppression really spanned the entire peri-transplant to late post-transplant because of all those issues that we've talked about. Communication and education also spanned multiple areas. The second question that we asked was, what troubling issue or problem most surprised you? And there was a lot of really fascinating answers. And again, they seem to break up into themes that we thought we could address in the network. Things such as, for our families, the amount of education that we provide, not just early transplant, but late after transplant, and information about complications and long-term challenges really were identified by our parents and families as an important need to focus on over the long term. And so we used these different plots to kind of evaluate cost, expertise, timeline, and priority, and we came up with 4 different kind of buckets of work, which I'll show you in kind of our last slide. And in this slide, we took all that information from our patients and families in our transplant centers, and we defined 2 different areas of focus, with each having some potential projects that we have chosen to focus on. On the left side, we identified topics that were really keying around patient and family identified themes, which broke out into mentoring resources and family care resources, development of online tools or a self-management book, refining and making the ideal outcome, really talking about that among families. What is the best outcome for our patients? What does it look like? And are we getting there? And then helping with metrics and tools for transition from adolescence to adult care. On the other side, we had a few different areas of transplant-focused projects that included working on standardization of immunosuppression, understanding what we're doing with immunosuppression, and then in liver transplant, reducing vascular complications by standardizing anticoagulation protocols. We also had some outside-the-box project proposals on using artificial intelligence to help organ donor selection and maximizing the utilization of the precious resource of organ donation, which is important in this week that we focus on. We have now chosen in our network over this year in the patient and family group, to begin a quality of life survey, as well as a transition of care survey to understand where patients are in this transition and transfer process that I talked about early. And in the transplant health, we've chosen to look at immunosuppression and reduction of vascular complications or improvement of vascular or bleeding complications. I want to leave some time, but this is a favorite cartoon of mine. I think there's a lot of highly motivated people on the call, and I'm really thankful for your time in joining us this morning. We have a lot of plans, and sometimes we don't do so well, but we just need to keep going. And we need to continue to work hard and to encourage one another and not get discouraged. So in summary, I really hope that, that this has helped you to look at the whole cycle of care. I think in order to improve, we need to focus on the big picture as well as the specific elements. We need to try to understand the challenges that we want to tackle. We really need to engage with you, our patient families, and our patients to understand that we're doing what is important to them. And we need to try to look at new systems of learning and implementing these changes so that we can get the best practice out to the whole world. So I'll stop there and turn it back over to Melissa. And thank you so much for your attention.
Thank you so much, Dr. Mazariegos. This was a really engaging presentation, just so much wonderful information. We have got lots of questions, some on text and some pre-submitted for those that couldn't join us. The first question comes from Jen Lau. She wanted to know, what are some of the reasons why data is not being recorded to UNOS? I think that's in regard to the long-term data for outcomes.
Yes, great question. One of the challenges is that when a patient is transferred to another center for care, particularly at the adolescent age group, if that center is not a transplant center, then they stop submitting data back to UNOS. And so the GI doctor or the nephrology doctor may be a very good caregiver and is taking care of the patient in a good way, the best way that they're aware of, but they're not reporting that information back to UNOS because they're not part of a transplant center. That's probably one. That's a good way to explain why it's not being reported. There are also bad ways, like the patient isn't seeing any physician or isn't seeing a physician and is just somehow maintaining their medications, etc. That can also be happening.
Thank you so much. The next question, it says, do you feel more surveillance biopsies would help with monitoring graft survival?
That's a great question. I think that the issue of graft biopsies is a challenging one. I think we do need information. It is not standard practice yet in the United States, say for liver or for kidney, to do a protocol biopsy. And this is because it's not completely clear to the community what information that would lead you to do or how you would change care. I have learned a lot that by doing some immunosuppression withdrawal studies in the last 10 years, with our community that liver numbers that are normal in a patient that feels normal does not necessarily guarantee that the liver tissue looks normal. And this is only about, in our study of like 180 samples, only about of those type of patients, normal, very good function, no rejection in the past years, normal LFTs, only about a half of those patients actually had a normal biopsy, which is concerning, but it's also important information to know. And I think that it helped us to just realize that in order to withdraw immunosuppression or lower it, which we want to do, we really do need to have biopsy information. And for those that are on low immunosuppression, that biopsy along the way at some interval is important to kind of guide the clinicians and the families to really feel that their liver is doing well. So I think the frequency is not yet known. I do believe that we should do it, and at an interval that the centers can decide on.
So one of our offline questions, kind of opposite to this one, is there a future where we can check rejection without biopsy?
Yeah, so I think there is a future for that. With this study that we're doing with the, which is called IWITH, or immunosuppression withdrawal in stable liver transplant patients, we have done biomarker studies in patients that did come off or that didn't have rejection. And although the samples are relatively small, it's only 100 or so patients that were weaned, that we believe that may give some information. Right now, I think biopsy hasn't been replaced, though, as a guide to lowering or monitoring immunosuppression. That's still the gold standard. But I think I see a future where we can get where we can have a biomarker like that developed.
Excellent. A follow-up question to that is, would that be for unstable patients as well?
Yes. So my colleagues here in Pittsburgh have developed a marker called the Pleximmune, which has been validated in several organ systems and has shown a guidance for patients who had a tendency for rejection and who may need to maintain on immunosuppression. And that uses technology that is fairly standard now, and can predict when you have a rejection risk as compared to antigens that weren't from your donor. So it uses like the donor-specific antibody concept that I talked about to look for your response to those antigens and see if you have a greater response than to non-donor specific antigens.
I'm going to ask our last question from Tony, and then we will submit all of the rest of the questions in writing later on. Tony asked, how does your approach to patients and parents change as a pediatric patient transitions from being the one whose care is being managed to being the one who manages his or her own care?
Yeah, that's a great question, Tony. I think that we need partners, and so we need partners with our adult colleagues, and we need partners with our families and patients. So really look at it as a partnership where we are able to entrust the care to an adult provider, perhaps, once they're at the appropriate age at your center, but where we also where the parents also have to let go, and the patient has to accept and engage that. And so it's any kind of hesitation at one of those points, myself or the parent or the adult physician not wanting to engage, all of those things can kind of short circuit the process. But I think we do try to have the philosophy that we want to build this process so that by the time you're through it, that we trust that you're able to do it well, and that we are here to support you, not to not to manage everything, but we're here to support you, and that your other adult caretakers also are expert and can help you with the next stage. So it's a little bit of trusting and letting go that I think is critical for that process to happen.
Thank you so much, Dr. Mazariegos, for staying a little past the hour. Is there anything else you wanted to cover before we wrap up?
No, I think just give us, and by us I mean your physicians, your societies, give us your feedback on how we can listen better to you, and really we want to. I think that the stage of engaging with families in kind of looking at how to improve is critical, and I hope that we're going to do that with the Starzl Network, with all of our societies and work, and it's an exciting phase, but we really need family engagement. So I think that's why Transplant Families is so important, to really engage with their teams and the societies that are working in the area to make improvement happen and get communicated faster.
This is such great information. Thank you so much. And I definitely want to encourage everyone to go check out Starzl Network and some of the learning networks that are out there so you can engage in this level. It's definitely wanted. We appreciate you being here today, and we want you to bring awareness and celebrate National Pediatric Transplant Week with us. Use the hashtag Kids Transplant Week, hashtag Kids Transplant Week, to share your stories of inspiration for those that are new to the journey and need those stories to see your kids growing and doing well. We all want to see those. I want to go through a few webinars that are coming up. UPMC has a Facebook Live in about 5 hours. George will be on that as well, Dr. Mazariegos. And it will be on live donation. So please check that out. It'll be exciting. I know I'll be there. Transplant Families is co-hosting 2 more webinars later this week. On Thursday, we'll be working with another learning network, the Action Network, to talk about heart failure and ventricular assist devices with Dr. Peng. And he is the Assistant Professor of Pediatrics at Michigan Medicine, SNEPT Children's Hospital. We'll be co-hosting that with Children's Cardiomyopathy Foundation. The last webinar this week, also co-hosting with Children's Cardiomyopathy Foundation, will be highlighting pre- and post-transplant emotional considerations with Dr. Casino. She is Assistant Professor of Pediatrics at University of Michigan Transplant Center, SNEPT Children's Hospital. And you don't want to miss that one. I know we always have a lot of questions with the care of our children and the family as a whole going through transplant. We thank you so much for taking time this morning to join us today, and we very much look forward to seeing you next time. Please stay tuned for a recording of the webinar coming your way soon, and feel free to submit any questions. Thank you, Dr. Mazariegos, for joining us today.
You're welcome. God bless you. Take care, everyone. Bye-bye.
Bye.